Okay, so this is my disclosure statement. So in terms of talking about women of reproductive age, we are appreciating more and more in our field that the disorders that we treat often start very young. So many women come to the reproductive age window already having been diagnosed with a disorder and maybe already on treatment with a medication. So we know that many women will already be receiving treatment at a time where they may be starting a family. And also many women, of course, are diagnosed and treated for the first time while they're of reproductive potential. Okay. So for this slide, it was supposed to be a little bit of a quiz. What % of pregnancies are unplanned annually? There wasn't supposed to be the answer on this slide, so I spared you the suspense. About 40% of pregnancies globally are unplanned. And when we look specifically at the U.S., it's even higher. So for those of you that prescribe medications, probably the most important thing to remember from this presentation, while you're eating your lunch, checking your email, playing free cell, maybe you're just listening, but if I could just have you remember one thing from this presentation, it's that about half of pregnancies in this country are unplanned, which means that we really need to keep in mind the reproductive safety profile for all women we treat if they're of reproductive potential. And also in terms of the treatment of girls and young women, because we want women to be doing well on whatever treatment they're on when they do get to be of reproductive potential if they're started earlier. So that's probably one of the most important points, I think, in the field of perinatal psychiatry. So, just making the point again that there's a high risk of unplanned pregnancies, which doesn't mean that they're not wanted. It just means that the woman wasn't planning on becoming pregnant at that time. Now, in terms of healthy pregnancy, healthy conception, there are many things that we can talk about with patients that not only would be conducive to a healthy pregnancy, but just a healthy life in general. So those would include maintaining a healthy weight and exercise. We know that having a psychiatric disorder is associated with a higher BMI, and obesity is associated with higher risks in pregnancy. So the patients we treat do tend to be higher risk because of obesity. We want to encourage women not to be using illicit substances. If they're pregnant, to be abstaining from alcohol, tobacco. Also, regular physical activity, regular exercise is recommended during pregnancy, so moderate exercise most days, even if women were not already exercising prior to becoming pregnant. Also, taking folic acid is very important in terms of healthy pregnancy, not just during pregnancy, but leading up to pregnancy. So pre-conception, folic acid is very important. So in general, there is some debate whether most of the population should be on a regular multivitamin. That's really debatable at this point. It's not clear that it's necessary, but for women of reproductive potential, it's very important to be taking folic acid or a multivitamin just to make sure that they're getting those the protection that confers against, for example, neural tube defects and other central nervous system problems. Okay. Now, in terms of assessing different treatments, especially medications, in terms of risk during pregnancy, we have to keep in mind that pregnancy itself is inherently risky. So many times without any known reason, things can go wrong during pregnancy. And I think very often when the public hears that there may be a risk associated with something, or we think about any medication exposure in pregnancy, we often don't put that in context. So pregnancy is associated with risks itself. One of the biggest risk factors is advanced maternal age. We know that having untreated psychiatric disorders also increases the risk of obstetrical complications and neonatal complications. The baseline rate of malformations in this country is about 3%. So that's, without having any cause, about 3% of deliveries are complicated by some type of major malformation. The rate of prematurity in this country is about 11 to 12%. Gestational diabetes is actually increasing as the rate of obesity is increasing in this country. And of course, we know that alcohol, tobacco, and other illicit substances really increase risk, and alcohol is one of the, really most infamous known teratogens. Okay, so in terms of medication during pregnancy, it's really hard it's very hard to simplify this topic, basically. And for many years, the U.S. FDA historically has had pregnancy categories, so A, B, C, D, X. And there have been a lot of problems with these categories. And as of 2015, summer, they've actually been eliminated going forward. So new drugs that are now approved will not have a letter assigned. So, there are pros and cons. So these letters have always served us poorly because they don't take into account the untreated disorder and those risks. They don't take into account all the data available. So what would happen is a new drug would come to market. There would be no requirement for human safety data, just a little bit of animal data, and then a letter would be assigned based on that, which is not very helpful. So a little bit of animal data doesn't tell us much about human pregnancy. And then many drugs that were older that there may have been a lot of data for would not have an updated letter. So even if, there have been medications in psychiatry that may be first-line medications to use in pregnancy, yet they may not have a favorable letter category. So those medicines that already have a letter, those will take some time to be phased out. But you can't go by the letter. You really need to know the human pregnancy data for medications that are used during pregnancy because the letters are so misleading. I would even say that they're seductive. I think that they're overly simplistic. They lead us to believe we know more than we do, and that the risk-benefit analysis is simple. And it isn't. But as these letters get phased out, this is what we're going to see in the package insert section. The first priority of this section is going to be human pregnancy data. Registry information, like prospective registry data, will be first, and then all human data summarized. And so, it's going to be tricky. It's going to be challenging because what it will require is really that healthcare providers and patients really are able to interpret that data. And, this is really going to be something that needs to be done across disciplines, across different patient education levels. So I think it'll be challenging to see how the new system is implemented, but it also is a good change, a good but a daunting change. In terms of untreated psychiatric disorders and risk, really all psychiatric disorders that have been treated that have been studied do seem to increase the risk for pregnancy if they're not treated. So this is true of depression, anxiety disorders, bipolar disorder, schizophrenia. If a mom is not well, it does increase the risk of complications for the pregnancy. Depression itself, most commonly, what has been found in studies is that babies may be premature or low for gestational age. That's very important because there's also been a suggestion in the literature that antidepressants may also be associated with that. Babies may also be more fussy, sort of different stress response at delivery, which also we need to tease out from perhaps effects of antidepressants. And if moms are not well, they're also less likely to be doing all the preventative health care things and engaging fully in prenatal care. Anxiety also has been studied in this context, and untreated anxiety also poses risk. So, in a way, we need to think of the untreated psychiatric disorder as an exposure itself. So, for example, we can easily conceptualize with anxiety disorders like panic or PTSD that there is a physiologic response to having those disorders untreated during pregnancy. For example, changes in stress hormones, which have been postulated to increase vasoconstriction, may limit oxygen delivery to the fetus. So more higher risk of obstetrical complications. And in terms of long-term follow-up, it's also been demonstrated in studies that mothers who have untreated anxiety during pregnancy may have kids who have some biobehavioral differences later in life, like attentional problems. In terms of guidelines, we have the American Psychiatric Association and American College of Obstetricians and Gynecologists, who teamed up together to do recommendations for the treatment of depression in pregnancy. And what they basically recommend, makes a lot of sense, that psychotherapy should be considered first line for more mild depression. And really, it's hard to think of any treatment plan for any severity of depression where we would not include a form of psychotherapy. So in our group, we tend to refer a lot for cognitive behavioral therapy because of its very acute and immediate focus on symptom management, which is really essential during pregnancy and the postpartum. We want to focus on lifestyle components like nutrition, exercise, treatment for substance abuse, all of those things. From a medical legal perspective, it's really important to document all exposures going back to conception. So this would include prescription medications, over-the-counter substances. And it's really important also to ask women when they found out they were pregnant and if their use of any of those agents changed. So very often women will say, I stopped smoking when I found out I was pregnant. So the key is, when did she find out she was pregnant? Because some women will know that they're pregnant right away. They may be tracking or know their cycles very well. Some women may not realize they're pregnant until months into a pregnancy. So that's really important to find out. Now, for women who are well and on an antidepressant and either newly pregnant or planning pregnancy, then there are a couple different choices. Some women may decide they want to stop medicine for pregnancy. Some women may want to continue, and that is very much an individual a decision made on an individual basis, really collaboratively with healthcare providers. So women may have very different preferences about what they want to do, but their own course of illness will very much inform really what are the most reasonable courses of action. So if someone has had a really serious and recurrent history of severe depression, and knows that when she stops medication, she's at very high risk of recurrence, it may be completely reasonable to continue her medication during pregnancy. Now, for women who are not well, they're depressed and planning pregnancy, what we want to do is really encourage a period of wellness before pregnancy. This gets a little tricky with older moms. A younger mom, say in her 20s or early 30s, may be able to take 6 months to a year off and really focus on her wellness. But for older moms, like later 30s, sometimes even early 40s, we see many of those women, it may make a major difference in their fertility whether or not they wait to try and conceive. And for women who have more severe depression, antidepressants are absolutely considered first line during a pregnancy. We just want to make sure that the selections are rational. So we want to pick medications based on their reproductive safety profile, looking at the quality of the human data. But we also want to know what a woman's been responsive to in the past, because it doesn't make any sense to expose a woman during pregnancy to a medication that is unlikely to work for her. And also we want to minimize the amount of time that a woman may spend ill. So I want to talk about some of the main topics regarding safety of antidepressants during pregnancy, but I can't possibly cover them all. But I do want to put in a plug for our website. If there are any new issues or really pressing issues about antidepressants or other medications during pregnancy, please see our website for more comprehensive information. We have our face pages, for example, pregnancy section, but we also have what's called our blog section, which is basically like mini research updates on information that has to do very often with medication during pregnancy. And that's, I believe, the website is on the slide, but if you just Google women's mental health or MGH women's mental health, it should pop right up. Okay. Now, in terms of the SSRI antidepressants, we have a lot of information about antidepressants during pregnancy, particularly SSRIs, but it seems like the more we learn, the simpler the picture doesn't get. And partly because when you study something a lot, there's bound to be some inconsistent data. And also, it seems like when something more worrisome comes out, the media really picks up on the more worrisome things and not the more reassuring things. So it seems to be that in terms of sort of public perception, and even among healthcare providers, that there may be more danger than there really is with this group of medications. And that we literally have decades of study now of SSRIs and exposures during pregnancy and pregnancy outcomes. And the preponderance of the data shows that SSRIs are not associated with birth defects. The question is probably remains the most open about paroxetine in particular, and first trimester exposure and risks of cardiovascular malformations. Now, some recent studies that control for mom's depression and some other factors have not shown an increased risk of cardiovascular malformations, but really more consistently than other antidepressants, this has been raised with paroxetine, which is often not considered a first-line antidepressant during pregnancy these days. Regarding long-term data, because that's so important to our decisions, and we really wish we had more of this information for all of the medications that we use. Following up on SSRIs, generally the information is very reassuring. It's complicated though because the studies don't separate out for antidepressant exposure versus untreated mood or anxiety problems, and then also the exposure for the children of the mom's illness during the childhood, which we know is very impactful, that having a mom who's depressed really impacts development quite a lot and quite globally. But for most of the information we have does not show any negative impact of antidepressant exposure long-term on kids exposed during exposed during pregnancy, excuse me. There have been some studies that use very sensitive batteries that show that kids exposed to SSRIs may have some slightly slower motor development or language development, where it may even be that they're still within the range of normal, but slightly behind peers of the same age at younger ages, and that they also may catch up. But so far we haven't seen any obvious, long-term impacts of antidepressants on development. Okay. So one of the big questions that's been raised is, are SSRIs associated with an increased risk of autism if moms were taking them during pregnancy? And this is a situation where we have a number of studies. There was one that just came out last week that I don't have on here, that was published in JAMA Pediatrics. But there have been large studies that do not show any risk of autism, including the one that was just published last week by MALM, M-A-L-M, and I'm sorry I don't have it on this slide. So some that show no association at all, and then some that show that there may be a small association. Now, what's really challenging about this is that, first of all, it's hard to discern cause and effect from these kind of studies. Because we know, for example, that there are genetics involved in autism, and families where there are psychiatric disorders are also more likely to carry a risk of autism. Also, we don't know if maternal severity of depression or expression of depression during pregnancy would be associated with an increased risk of autism. And most studies that look at really any questions about medication exposure and outcomes during pregnancy don't control adequately for the untreated condition or the untreated disorder. So that's another variable. So basically, this is a common dilemma in perinatal psychiatry, is how do you integrate studies that some show no risk and some show a small risk? How do you really put that together for patients? Now, if something is a teratogen, meaning it causes a birth defect, then it should do so consistently across studies and be the same type of problem. So really in autism, we don't have that right now. There's still, I think, a question. We could use some more research where really the maternal condition is controlled for better. But at this point, we are getting very large studies that aren't showing an association. So basically, this is a question that we hear a lot from patients. Right now, the data are not compelling and consistent that there is a link with autism, but also, on the other hand, we don't want women exposed unnecessarily to medications during pregnancy. So if they don't need to be on medications, really for any reason and really for the unknown, because we don't know 100%, we wouldn't want people on unnecessary medications. Now, later in pregnancy, there are a couple concerns. One that sounds really scary, but looks less and less like it's a true association, is persistent pulmonary hypertension of the newborn, or PPHN. There are some known risk factors of that condition. It's a serious but rare lung condition in newborns. Having a C-section is associated with higher risk. Being African American, being Asian, obese, having diabetes, asthma are all associated with an increased risk. And about 10 years ago, there was a study that raised the question, are SSRIs in the second half of pregnancy associated with a higher risk of this condition? Since then, other studies have not shown the association at all, and the US FDA has said not to change treatment based on this concern because it's not looking like a compelling association. Now, recently, there was a very large study that looked at this question. It was a large Medicaid database, almost 4 million pregnancies, and they didn't control for depression in this, but they found that with SSRI exposure, the risk was 0.3%, so very small, but not nothing. But without antidepressant exposure, it was 0.2%, so there was a sliver of a difference. We don't know, it's not a significant difference. And so we don't know if it was just by chance or there's something associated with being on an antidepressant. We just don't know, but it's such a tiny difference. And really, this kind of study also puts for us in context that, that the risk isn't zero without an exposure, even though we often, think mostly about medications and risk. We, of course, have to think that sometimes these risks happen in the absence of medication. Now, it has also been reported that babies may have a few days of symptoms after delivery. What we mostly see is some fussiness or jitteriness in babies. There have been reports of other medical problems like respiratory difficulties, but what we hear most about from our neonatologist colleagues is really fussiness and like difficulty to soothe and some jitteriness. And that's if patients report anything that their babies may have had, it's that. It's been suggested without anyone doing study that, in the package inserts, that women seriously consider stopping their medication in the third trimester. Now, perinatal psychiatrists have generally been on the same page, but that is not a good idea, and that is not standard practice. And that's because it's really the same women that are at high risk for postpartum illness are the ones that are on medication in the first place. And the last time, in life that we want a woman relapsing to a psychiatric disorder is when she's bringing a new baby home from the hospital. It's such a physically and emotionally demanding time. We want people to be well, not relapsing. So it's not something that we've done. However, since that recommendation came out, there was a Canadian study that looked at moms who did taper during a third trimester and those who did not. And they did not find a difference after they accounted for other variables like mom's burden of depression, anxiety, obstetrical complications. So it doesn't appear that there is necessarily any advantage in these neonatal symptoms if women do stop the medication in the third trimester. Now, Bupropion is another medication that hasn't received quite as much study but has received study in pregnancy. Most of the studies do not show an increased risk of malformations, although fairly recently there was one study that showed a small risk of cardiovascular malformations. So that hasn't been repeated. It hasn't been a repeated finding thus far. And we have to keep in mind also that Bupropion is a medication that can help some women stop smoking or refrain from relapse to smoking during pregnancy, so may have a specific use among some women. We also know that pregnancy is not protective against pregnancy, and that it appears that stopping a medication is associated with increased risk of relapse to depression. So in a prospectively followed cohort, women who stop antidepressants do have a higher risk of relapse than those who don't stop antidepressants, but it's notable that even with continuing maintenance treatment with an antidepressant, there still is a substantial risk of depressive relapse. So about a quarter of women who stay on medication may relapse, even though a much greater amount that come off medication may relapse. So it's really an important time across pregnancy to monitor for mood, and exquisitely so if women are stopping medication. Okay. Regarding pharmacokinetics and dosing needs during pregnancy, some women will need higher doses of medication in later pregnancy. This is most true for some of the mood stabilizers, most consistently so for lamotrigine and lithium, although it can be true also for antidepressants. So for tricyclics, it appears to be the case, and for SSRIs, more on an individual level. We know that some women may metabolize SSRIs more rapidly. We don't typically check blood levels, but what we do is really, monitor very carefully in the third trimester and know that some women may be processing medication more rapidly, maybe metabolizing more rapidly, and may need a higher dose in later pregnancy to maintain the therapeutic benefit. Now, switching gears to the postpartum, there's the postpartum blues, which is actually part of the normal experience. So the majority of women will experience the blues, which is transient, mild symptoms, maybe sadness or women feeling more emotional or crying. But it's not, the real deal. It's not a depressive episode where someone is pretty pervasively affected by depression really across arenas in their life. And it's much more described as, women, quote unquote, feeling emotional or hormonal. And it could also be sleep deprived, may also heighten some of that too. So if someone has the blues, we want to watch and make sure it's not the beginning of a major depressive episode. But generally, women do well without any medical intervention, with some support and sleep. Postpartum depression is a major depressive episode occurring in the postpartum. There's actually some debate over what the definition of postpartum depression should be. DSM-5, DSM-4 have been very narrow, and there isn't actually a formal diagnosis of postpartum depression, but it's major depressive episode with postpartum onset. Now, advocates and patients in the area of postpartum depression prefer to use the term postpartum depression and have it be more broadly defined. So basically a depression that's occurring in the postpartum, because they think it's really important for other people and healthcare providers to really understand that the context of the postpartum is special. So you may hear that word, those words used differently. We'll touch on postpartum psychosis and also considerations for bipolar disorder. Now, postpartum depression is common. It's actually been called the most common complication of childbirth. Anxiety is especially common and comorbid. So it's true with major depression in general that anxiety is commonly comorbid, but even more so with postpartum depression. And very often, women with postpartum depression have obsessions, so intrusive recurrent thoughts, very often very scary, can sometimes take form around either the baby's health or even harming the baby, which can be very frightening to women, but very much, kind of like classic textbook obsessions, like recurrent, intrusive, distressing thoughts that don't make sense and are very disturbing. We know that there are negative effects of postpartum and maternal depression on children, so affecting almost every area of child development. And so, it's really important, I think, that mothers understand that when they're taking time out or, resources to seek care for postpartum depression, that it's important that they realize that it's not selfish, that they don't need to feel guilty about it, that actually taking good care of themselves is taking good care of their families. And of course, we wish women would take care of themselves just because they deserve it, but very often we need to ally with women, that it is absolutely important for their children also that they get care. Now, breastfeeding is a hot topic. Now, we'll talk about medications and breastfeeding in a moment. And for the most part, it is absolutely compatible to be on an antidepressant and breastfeed. So that's not the issue. The issue that we see that causes the most distress is really the topic of breastfeeding in the context of depression and anxiety. So for many women, breastfeeding is not difficult, but for many women it is very difficult. And we have a whole class of healthcare providers, lactation consultants, because it's often difficult. Now, many women, really want to breastfeed, and for some women, if it's difficult, you can imagine that there's probably a bi-directional relationship between anxiety and depression and difficulty with breastfeeding. And some women feel so terrible if they don't breastfeed that it really takes a toll on their really whole life transition of becoming a mother, that they have so much really invested in the breastfeeding and often get bombarded with these social messages, breastfeeding is best, and from a nutritional standpoint it is. But when a mom is really suffering over this topic, it's important for her to know that her mental health is the most important thing. And that's the most important thing for bonding with the baby, not whether the baby is breastfed or bottle fed. So there are circumstances where we meet with women and we suggest they stop trying to breastfeed because it is making the situation for them so much more stressful or difficult. The other thing is it doesn't have to be all black and white. It is absolutely reasonable, and I think in most situations beneficial, if bottles are introduced from the beginning, either pumped milk or formula, so that someone else can help feed the baby. And that's so important because for vulnerable women, it may make all the difference if they can have someone else be able to help feed the baby. They can get more consecutive sleep. They don't have to be, really feeding the baby every 2 hours, 24/7, weeks in a row, and in that, very vulnerable sleep-deprived state where baby getting some more rest or self-care would make all the difference between being very ill or being well. And so that's a conversation, I think, that's really important to have during pregnancy so that women realize that it's not black and white, that you can still be a good mother and not breastfeed. And for many women, it really is a very emotional topic. Now, in terms of treatment for perinatal depression, for moderate to severe depression, antidepressants are our first line. It's very important for women to appreciate that. And we always want to use the lowest effective doses, but we don't want to underdose. The aim should be remission because it doesn't help if the mom is exposed to the antidepressant and still ill. So we want to make sure that women are treated to wellness. It is a time, especially with really complicated disorders or situations, to get consultation from perinatal psychiatrists. And of course, we want to maximize non-medication alternatives, which really psychotherapy being the most important. Now, this is a detailed slide, and I think the details themselves are not as important as just, an overview of the content. So the studies that are highlighted in blue are the controlled trials that have been done for postpartum depression. And there aren't very many of them, but from them, we basically can take away that antidepressants work similarly during the postpartum as not postpartum. So there doesn't appear to be a different selection process just for the efficacy of antidepressants. Now, the ones in gray are really little open, smaller open label trials, which don't, inform us as much. But I think it also shows overall that there hasn't been a lot of specific study for postpartum depression. Now, regarding antidepressants in breastfeeding, the bottom line is that for most antidepressants, they would be considered compatible during breastfeeding. Just some we have more data for than others, and some look a little better than others. So if a woman has never been on an antidepressant before, we usually start with sertraline because between sertraline and paroxetine, they both have the most mom-baby pairs in the literature looking at quantification of antidepressants that's in breast milk or baby blood levels, usually non-detectable without adverse events. So sertraline, because of its tolerability over paroxetine, generally is the first one selected if a woman has never been on an antidepressant. If she has been on an antidepressant, we want to definitely consider the one that's worked best for her because we don't want to have non-effective trials for that individual woman. Now, just some of the caveats of some of the other medications. Fluoxetine has a long half-life, so it's more likely than the others to be detectable in infant blood. But it's still compatible with breastfeeding. So even, we wouldn't switch from fluoxetine, say, during pregnancy to another antidepressant postpartum. And if a woman has been on an antidepressant during pregnancy, we would just continue that one. We wouldn't switch because the baby's already exposed to that one medication. With Bupropion, there are fewer studies. There are just some case reports that have generally showed low levels of exposure, but may play a particular role in women who are trying to either quit smoking, like we talked about before, or prevent relapse to smoking. There are some antidepressants that we really don't know very much about. There really haven't been these careful mom-baby pair studies. So usually it's the SSRIs that are picked the most, but if a woman has had very treatment-resistant depression, we might consider one that is not well studied. You know, if she's been on many different medications and something else has worked for her, we may consider that anyways. Now, switching gears to talk a little bit about bipolar disorder. We know that bipolar disorder relapse is associated with discontinuation of mood stabilizers, both during pregnancy and also not during pregnancy. So it appears that women are at extremely high risk of relapsing during pregnancy if they stop a medication. It also appears that the postpartum is an exquisite time for relapse in women who have bipolar disorder. The issue about stopping a mood stabilizer, though, is one that really deserves a lot of attention, that if women are changing their medication, to really make sure that they're being monitored extremely carefully and that they have a well-thought-out plan. Now, in terms of severe psychiatric illness, like requiring hospitalization, which is generally postpartum psychosis and bipolar episodes, those are increased in the acute postpartum, so maybe peaking within a month. Overall, postpartum depression or disorders that can be treated outpatient, it's actually not so clear, you know, how high the risk is postpartum compared to not postpartum. But in terms of bipolar disorder and postpartum psychosis, we know that those are exquisitely risky within the first 2 to 3 weeks or so. Okay. And postpartum psychosis is really an emergency. It's a psychiatric emergency. So it's estimated to affect between 1 and 2 women after delivery out of 1,000 pregnancies. Usually has a pretty rapid onset after delivery, but not always. You know, we've seen cases where the onset is later than expected. And there's a great risk of harm to the woman and to her infant and other children. We want to suspect bipolar disorder as the diagnosis. That's the diagnosis that mostly pans out after an episode of postpartum psychosis. And also there are other studies like genetic studies that support that as well. So again, it's a psychiatric emergency, and it's estimated that about 4% of women with postpartum psychosis commit infanticide, which is actually something that's like kind of hard to say out loud even. You know, it's just, you know, such a terrifying statistic. And it's really important, though, that if we see women who've had postpartum psychosis before, that they know how dangerous it is, and not just them, that if someone is pregnant or planning pregnancy with a history of postpartum psychosis, that they have their partner or family members, you know, come in for a consultation and really understand how risky this is, because the woman herself in a postpartum psychotic episode has very poor insight. So she's not in a good position to be able to assess care, but it's important that those around her are able to assess care and understand how serious it is, and also how recurrent it is. So women who've had postpartum psychosis before are at extremely high risk of having another episode. So it's been estimated somewhere like 70 or 80% risk of having another episode of postpartum psychosis, so very high. So the risk factors, you could see that, you know, maybe perhaps some obvious risk factors for having postpartum psychosis here increase the risk substantially. So hospitalization for a psychotic episode during pregnancy, previous hospitalization, for example, like these really do increase the risk. And the risk with bipolar disorder is thought to be 2%. So the population that we treat in mental health is, you know, much more at risk than the general population. So we may hear it's a rare condition, but among vulnerable patients, it's not so rare. Now, it can be difficult sometimes to separate out what's postpartum OCD and what's postpartum psychosis. And this happens often in the context of a woman who reports having thoughts of harming the child or expresses thoughts of harming the child. And really the key difference is really insight. So a woman with postpartum OCD knows she's having thoughts that don't make sense and are extremely disturbing. And really recognize it as such. She has good insight. But for postpartum psychosis, it's not usually recognized by the individual woman as delusional, although people around her may realize that her thoughts are delusional. So it can be difficult to sort out, for example, in an emergency room or but generally, postpartum OCD is treated along with postpartum depression. It may occur with postpartum depression or on its own, and usually gets better with treatment as an outpatient, whereas postpartum psychosis is generally a situation where we want to have the woman hospitalized to avoid risk to herself or anyone else. Now, mood stabilizers in pregnancy we'll touch on. Epstein's anomaly is a known teratogen, meaning lithium is a known teratogen. It increases the risk of Epstein's anomaly, which is a rare cardiovascular malformation, but it's a very rare malformation. So even with the increase that lithium causes, we know that it's still a low absolute risk. So if women are on lithium in the first trimester, the risk is estimated to be between 0.1 and 0.2%, so still low. So if women are able to come off lithium during a first trimester, then sometimes that's what we do. But there are some women that are exquisite responders to lithium, and when they come off lithium, they get extremely ill. And we have had situations where women do continue their lithium throughout pregnancy. And so in those cases, we recommend some additional obstetrical monitoring for fetal echo at the time of the level 2 ultrasound to really allow some imaging of the heart. But in general, it may be a reasonable risk for women who have had severe illness and are lithium responders. For women who are on lithium during pregnancy, it's also important to know that it is excreted more rapidly in late pregnancy, and women may need higher doses in later pregnancy to maintain the therapeutic benefit. Okay. Now, the worst teratogen known to psychiatry, and one of the worst teratogens, really that's a commonly used medication in women is valproic acid or valproate or Depakote. So the risk of neural tube defects may be higher than 10%. And it's not just that risk of neural tube defects, but may cause some neurodevelopmental problems that are very long-lasting and substantial in that child's life. The thing about neural tube defects is that the neural tube closes very early in pregnancy, actually before most women would even know they're pregnant. So it's extremely important that women of reproductive potential and girls not yet of reproductive potential, it's important that they do not get treated with valproic acid. Okay, so it's always a horrible dilemma when women come in stabilized on valproic acid and are planning pregnancy, or even worse, are already pregnant. So we want to forget valproic acid exists in women until they're postmenopausal or no longer have a uterus. So no valproic acid for women of reproductive potential. And fortunately, we have lots of other alternatives, but we should just be really aware of that risk. And in terms of the longer-term follow-up, so this is a slide. So neurologists have done a great job keeping pregnancy registries. And they have not only studied anticonvulsants in pregnancy, but also done neurodevelopmental testing on kids after in utero exposure. And this slide is from a study looking at kids at 3 years of age, but it looks pretty much exactly the same for kids at 6 years of age. So kids exposed to valproic acid score more poorly on IQ tests, significantly lower compared to controls. And you can see from the lamotrigine group that they score really right on target with the general population. So a mean of 101, the average is 100. They're right on target with the general population. whereas valproic acid substantially below the mean. Okay, so lamotrigine, the more we learn about Depakote, the worse it looks. In pregnancy, the more we learn about lamotrigine, the better it looks, actually. So at one time, we thought that lamotrigine might be associated with an increased risk of oral clefting or cleft palate with first trimester exposure. As studies have gotten larger, it looks like that's actually not true. So the largest studies, the most definitive studies, don't show an increased risk of oral clefting or cleft palate or cleft lip with lamotrigine. So lamotrigine does not appear to be associated with any type of birth defect. So it's looking good in terms of that, in terms of its reproductive safety profile, also in terms of long-term neurodevelopmental follow-up of the kids. And the thing that I think is so important about lamotrigine is that, very often women stop their medications when they find out they're pregnant or they're advised to. And with lamotrigine, once women stop lamotrigine, they have to start over in terms of the dosing. So start over at 25 milligrams a day, going up by just 25 milligrams every 2 weeks. So it may take months, really, to get back up to a therapeutic dose. So lamotrigine is always one of the medications that we want to make sure that the decisions around stopping it are very thoughtful, because if it's something that's really helping the woman, it may make it very difficult to have her be restabilized because it takes so long to restart the medication. Okay, regarding atypical antipsychotics in pregnancy, just a few years ago we had almost no information about this, and now we are really getting quite a bit more. So we have had some registry studies that generally have not shown an increased risk of malformations. There was one German study, which is one in the middle on this slide here, that suggested that there might be an increased risk of cardiovascular malformations, so very small risk with atypicals compared to control. So, healthy women, no exposure, but that hasn't shown up in other studies that have looked at the same question. It's important to note with most of these that it's usually more than one medication that a woman is exposed to. So in these registries, a woman is not usually just on an atypical. She's usually on other psychotropic medications as well. There was recently a study with no control group, but a publication that came out of an Australian registry study, and the reason I'm showing it to you, even though there was no control group, is to just really note the high rate of gestational diabetes here in women on atypicals, and also prematurity. So those are two things that we're hoping to learn more about as well as we get more and more data on atypicals. And of course, we may not be able to separate that out from the untreated disorder or the rates of obesity that may or may not be related to the disorders or the medications or a combination. We have an antidepressant registry at Mass General Hospital, and I'm going to give you the information for that in a minute. But so far, we have not seen an increased rate of malformations in women exposed to atypicals versus controls. And our controls are generally other women who have psychiatric disorders but are not on atypical. So in terms of some similarities, it's generally a similar group of women except for which medications that they're on. So reassuring data thus far. And the first paper that came out from this registry was just published in the American Journal of Psychiatry this year. So if you're looking for the full paper, it was just published in the American Journal. And this is our registry data. If you see pregnant patients and you would like to be able to refer to our registry, this information is on the homepage of our website, or email me and I will make sure you get information. But any woman who's pregnant can be in the study because she can either be in the atypical group or she can serve as a control. It's all by telephone, 2 phone calls during pregnancy and 1 postpartum. And in real time, this is helping women who are on atypicals really understand the risks and benefits of exposure. So we are absolutely so grateful for any patients that you refer. And my email, I believe I'm showing you at the end, but it's mfreeman, M-F-R-E-E-M-A-N, @partners.org if you want information on that. Okay. Now, I'm just going to touch on breastfeeding and mood stabilizers to say that, really lithium is the most, I just want to notice in the corner of my eye, I saw my email address was posted. just so there's no confusion, I actually have 2 email addresses. They're both the same account, so don't worry if you write down one and not the other. They're the same account, I promise. In terms of lithium and breastfeeding, it's really the one medication that we generally consider contraindicated during breastfeeding. It's not officially contraindicated now. At one time it was by the American Academy of Pediatrics. Now it's in a category that's almost contraindicated. So, there have been cases of babies having high levels of lithium in their system and adverse effects. So it's a medication that we do not encourage women to breastfeed on, although sometimes we have women who want to do it anyways. And so Adele Vergara, who was at Mass General years ago and is still a very active colleague of ours, did a study looking at mom-baby pairs where the moms were treated with lithium and looked under, what circumstances or are there some guidelines where it might be okay. So really I want to emphasize that we don't encourage women to breastfeed on lithium. There's some gray area for almost every other medication, even some where there are some great unknowns. But for lithium in particular, if a woman is really enthusiastic about breastfeeding, if she's on a low dose of lithium and not a lot in terms of other medications, if the baby's healthy full term, if the mom and pediatrician are willing to monitor some labs and have the pediatrician follow along carefully, and if the pediatrician agrees that it's a reasonable plan. So it's not something that we see very often. I think I've had maybe 3 patients who have been on lithium and breastfed. They really wanted to. They were on extremely low doses and did okay, but it is a very unusual clinical situation for us. Okay, so on that note, I will stop, and I believe that there are some questions that came in, and I'm just looking to see how I pulled them down. So it looks like there was just one question that came in so far, and that's, can you please comment on the role of omega-3 fatty acids in pregnancy for mood or anxiety, and do you suggest EPA to be high? Well, I have to say that this has been an area of a lot of interest for me. It's been an area where I've actually done some research myself, and with omega-3 fatty acids, really their best study in psychiatry has been as an add-on treatment to patients with depression who are already on antidepressants. And with those studies, it looks like they may offer some benefit in addition to the antidepressant, but they generally haven't been studied as monotherapy. And the meta-analyses have generally been positive in terms of mood disorders, but the effect size would be pretty modest. Now, there have been some specific studies for the acute treatment of depression in pregnancy, which have been mixed, with only actually one study showing a benefit in a small treatment trial. But I think from a pregnancy standpoint, there are other pregnancy benefits of using omega-3 fatty acids. For example, they appear to slightly lengthen gestation. So for a vulnerable population that may be predisposed to have preterm delivery based on psychiatric disorders or medication exposure, that may be a benefit. Also, it's been postulated that there are some neurocognitive benefits for babies. So if there may be an add-on antidepressant effect, then I think, and women would like to take it, I think that it's absolutely a great part of the treatment plan. In general, I think that it's important that we're just really thoughtful about what supplements women take during pregnancy. We want to make sure that they understand that natural doesn't mean safe, that many natural compounds are not well studied in pregnancy, and that many have contaminants. And there was recently an excellent PBS Frontline special on this topic. If anyone is interested, it was really well done. About how very commonly there are contaminants in supplements. Now, omega-3 fatty acids, I think, are actually an exception to that because there have been studies looking at contaminants that have generally been very reassuring. Now, in terms, though, of the EPA-DHA, so EPA is eicosapentaenoic acid, DHA is docosapentaenoic acid, and what we generally see in studies that show a mood benefit is higher EPA to DHA. So generally the ratios being anywhere from 2 to 1 to 5 to 1. What's mostly studied in pregnancy is what's generally most available commercially, which is something like 2 to 1 or 3 to 1, not the super high EPA ratios. So I usually stick with what's already been studied in pregnancy, which is like a modest higher EPA to DHA, so 2 to 1, 3 to 1, or 3 to 2. Which is actually consistent with most commercial brands. And in terms of total dose, with omega-3 fatty acids, it does not look like more is better. It looks like the sweet spot for dosing is somewhere around 1 to 2 grams total of the EPA and the DHA. Oh, any issues with stimulants? That question just came in. Really excellent question. So, you know, I didn't talk about a lot of the other psychotropics, but with stimulants, the main issue is fetal growth rather than malformation. So there have been a few studies now that have been carefully done, have not shown that methylphenidate, which is Ritalin, it doesn't appear that these are associated with major malformations. There's an older literature, but that's primarily looking at women who've used stimulants as substance abuse. So the issue is not primarily malformations, but fetal growth. So the babies appear to grow small for gestational age if moms are on stimulants. You know, and most of the women we see who are on stimulants are on them for ADHD, and many women can function well without their stimulant. So we generally discourage the use of stimulants during pregnancy and breastfeeding. There may be occasional situations that are exceptions, but for the most part, we don't have women take stimulants during pregnancy. Okay, thank you so much. This has been a real pleasure for me, and thank you for taking time out of your, I'm sure, extremely busy day. Thank you.